On that note, ladies and gentlemen, we are about to commence our first academic presentation of the night. This will be titled NAFLD to MAFLD and Beyond, Characterizing Steatotic Liver Disease in Sri Lanka. I'm honored to invite Professor Madhuril Niriyalla, Professor in Gastroenterology of the Faculty of Medicine, University of Kelaniya, Ragama, on stage to deliver his address.
Good evening, ladies and gentlemen. It's a privilege to be here to share something on a disease that we see quite commonly in our clinical practice. So I'd like to thank the organizers, PG Health, for the kind invitation to come and deliver this talk. So my topic is NAFLD to MAFLD and Beyond, Characterizing Steatotic Liver Disease in Sri Lanka. So in the next half an hour, I'd like to talk about NAFLD and the scope of the problem, the epidemiological studies that have been done on NAFLD in Sri Lanka to show what kind of problem we are dealing with, and also to wind off with studies on the NAFLD outcomes in Sri Lanka. The current definition of non-alcoholic fatty liver disease requires the demonstration of hepatic steatosis, that is more than 5% of liver fat. That is done mostly with imaging, that is ultrasound, and very rarely on histology. And this should be in the absence of any secondary cause for fatty liver, and that is mainly to exclude unsafe chronic alcohol use. And also there should be no competing causes for hepatic steatosis like drugs or hereditary liver disease. And there should also not be any coexisting chronic liver disease. So as you can see, this is a very restrictive and sort of a limited definition that needs strict exclusion of other liver diseases and other causes of fatty liver to come to a diagnosis. So it is a spectrum of disease ranging from simple steatosis, which is the earliest form of the disease, where there is only liver fat. There can be mild inflammation, but never any fibrosis. So in clinical practice, most of our patients will belong to this category. About 75% of our patients will only have simple steatosis. With time, these patients can progress to the more advanced form of the liver disease, that is non-alcoholic steatohepatitis, where there is fat deposition and more inflammation, and most importantly, there will be liver injury, hepatocellular injury, as well as varying degrees of fibrosis in this advanced form. And these patients, the NASH patients, will account for about 20% of our clinical practice. The patients that we see with fatty liver, about 20% will be NASH. And with time, these patients are the ones who will progress to very advanced bridging fibrosis and nodule formation. And those are the ones, those who will have NASH-related cirrhosis, which is the end-stage disease. From more recent studies, we know that this linear progression from simple steatosis to steatohepatitis to NASH-related cirrhosis, it's not always there. About 20% of patients, unfortunately, can progress very rapidly from simple steatosis to cirrhosis, and that's an alarming finding. So what about the pathophysiology of non-alcoholic fatty liver disease? There is contribution from altered gut microbiota, oxidative stress, and lipotoxicity, which propagates the liver injury. And this is usually in a patient with genetic predisposition. And what are these genetic risk factors? They are usually single nucleotide polymorphisms, namely PNPLA3, TMF6SF2, GCKR, and MBOT. And an individual who has these genetic predispositions or the genetic variants, if they are exposed to unhealthy lifestyle, namely unhealthy dietary habits containing very high calories, a westernized diet, and a fructose-enriched food intake, coupled with low habitual physical activity or sedentariness, will result in fatty liver. And in the early stage of the disease, this is asymptomatic. There will be no symptoms. With progression through early childhood, early adulthood, there will be progressively accumulation of cardiovascular risks, and the patient can develop cardiovascular disease. And when they get much older, they get end-stage liver disease, cirrhosis, and hepatocellular carcinoma. What do we know about the epidemiology? Although COVID got all the attention as the pandemic, this is the real pandemic. NAFLD is a global pandemic, which is a silent one, which is still very prevalent and is ongoing. If we take the worldwide data, about 25% of adults will have NAFLD in almost all the continents. And this is twice that much in diabetic patients. The prevalence can be as high as 56%. What are the risk factors for NAFLD? NAFLD is very closely associated with the metabolic syndrome. If we take patients who present for bariatric surgery, who have a BMI of more than 35, about 90% of them will have NAFLD. About 70% of our diabetic patients and those who have simple obesity will also have NAFLD. And if you take the patients with metabolic syndrome or just simple dyslipidemia, again about 50% of them will have NAFLD. So NAFLD is very closely associated with the features of the metabolic syndrome. Not only that, having NAFLD will predict future disease. This is a multi-system disease. So having NAFLD will give a risk of 2 to 5 times of future diabetes, 2 times risk of heart disease, 2 times risk of chronic kidney disease, and a 2 times increased risk of colon cancer in males and breast cancer in females. So this is a multi-system disease. What are the outcomes of NAFLD and NASH? As I told you earlier, the more aggressive form of the disease is NASH. And it's very clear that patients who have NASH will have 6 times overall all-cause mortality compared to just simple steatosis. Over a period of 18 years, the NAFLD or simple steatosis mortality is around 3%, and the NASH mortality is about 18%. And if you look at the leading causes of death among these patients, it is not liver-related, it is cardiovascular. So we have to be very careful in managing these patients and to screen them for the metabolic risk factors and correct them. Otherwise, they are going to die more of cardiovascular events rather than liver-related disease. The presence of liver fibrosis is the strongest predictor of bad outcomes, overall mortality, and severe liver-related mortality in patients with NASH. So compared to patients who have no or non-significant liver fibrosis, F0 or F1, those who have significant liver fibrosis, F2, 3, 4, they have more overall and liver-related mortality. So having fibrosis is a bad thing in NAFLD NASH. So because of this strong association with the metabolic syndrome and its components, and the lack of mention of anything in the current definition, there is a paradigm shift, and there is a suggestion that we should be calling this disease or defining this disease differently. So this term, the metabolic dysfunction associated fatty liver or MAFLD, is being suggested as a more appropriating term to define the illness, because we want to bring in the association, strong association with the metabolic risk factors. So if we compare these two definitions, both NAFLD and MAFLD will require the establishment of hepatic steatosis, usually on imaging. But MAFLD, interestingly, does not require exclusion of alcohol intake, does not exclude the need to exclude viral hepatitis or secondary cause of fatty liver. It just needs either the presence of diabetes or obesity. So here is the proposed definition. We establish hepatic steatosis usually by ultrasound or by persistent elevation of liver enzymes. And if either the patient is overweight or obese or has diabetes, we can diagnose MAFLD. If the patient is non-obese and is lean, that means they are not having obesity or not overweight and they are not diabetic, then we need 2 or more minor criteria, which can be central obesity, high blood pressure, raised triglycerides, low HDL, pre-diabetes, insulin resistant, or persistently elevated CRP. So 2 or more of these minor criteria with hepatic steatosis again fulfills the criteria for MAFLD. We will see how MAFLD compares to NAFLD later on. What do we know about NAFLD in the South Asian region? South Asia is home to 20% of the world's population. It's one of the most densely populated regions in the world, probably harboring a very large a number of patients with NAFLD and metabolic syndrome. However, the characterization of NAFLD in this region was very poor up to about 15 years ago. There were no large community-based prospective cohort studies from the region. This is one very recent paper published this month from our group in Lancet group of journals, where we looked at a meta-analysis of NAFLD among adults in the South Asian region, and we found that the high prevalence of NAFLD in the region comparable to the world statistics is about 27%. And interestingly, again, we are demonstrating that NAFLD is more common in those with metabolic disease. The prevalence among patients with metabolic disease is about 54%, twice as that of the general population. So it was significantly and independently associated with diabetes, hypertension, dyslipidemia, general and central obesity, and metabolic syndrome. And interestingly, many patients were non-obese. So needing a high index of suspicion, just don't go by the BMI. We have to look at the central obesity. So most of the epidemiological studies on NAFLD among adults in Sri Lanka comes from one single study, and that is the Ragama health study. This is now a completed study. It was a large prospective study, a community-based cohort study on non-communicable diseases among an urban adult multi-ethnic population from the Gampaha district of Sri Lanka, where I am from, where our group is working. So the location was the Ragama MOH area in the district of Gampaha. We carried out these surveys in 2007, 14, and 17. The adults were at recruitment, aged between 35 and 64. They were chosen by age-stratified random sampling from the electoral list. So very strict and very accurate sort of sampling, this representative sampling. The initial screening was in 2007. The reevaluation was at 7 years, 2014. They were also traced at 10 years to assess the cardiovascular events and mortality in 2017. So the definition of ultrasound for these studies were very strict ultrasound criteria. We had three criteria, and to diagnose NAFLD, there should have been two or three criteria. So these criteria were the increased echogenicity of the liver compared to the renal cortex or the spleen, obliteration of the vascular pattern. You can see on the fatty liver, if I can give the pointer. Yeah, so this is a normal liver. We can see the diaphragm in white. We can see that the liver echo texture is similar to the renal cortex, and we can see the portal vessels very clearly. In a fatty liver, the vessels are gone. The liver is very much brighter than the renal cortex, and the diaphragm is not very well seen because the liver is also relatively whiter than normal. So 2 out of 3 criteria or more should have been fulfilled to diagnose NAFLD in this study. So the NAFLD cases were fatty liver diagnosed on abdominal ultrasound. There should have been no alcohol or safe alcohol consumption according to Asian standard. And there should have been also negative for Hep B and Hep C markers. And the controls were those who did not have any feature of ultrasound criteria for NAFLD, fatty liver. And the adverse metabolic traits that we looked at in the initial cohort and follow-up was obesity, central and general, diabetes, hypertension, raised triglycerides, and low HDL. The outcomes that we looked at in 2014 were the all-cause mortality, fatal cardiovascular events, and non-fatal cardiovascular events. So this is the first study from this large community cohort follow-up. In this study, in 2007, we got a prevalence of 33% in this adult population. There was no difference between the ethnic groups. So very high prevalence of NAFLD even at that time in 2007. And obesity, insulin resistance, high diastolic blood pressure, fasting blood glucose, high triglycerides, raised ALT, and acanthosis nigricans was independently associated with NAFLD, and we found that from the study. We also looked at the genetics. I briefly touched upon the genetics in the pathophysiology. I was talking about this gene, the PNPLA3 genetic variant is the strongest genetic signal for NAFLD, which was described in other populations. And we were able to show that for the first time in a South Asian population in our Ragama health study, that this was the gene that was significantly associated with NAFLD in our group as well. So after a 7-year follow-up, we got an annual incidence of 6%, which is very high. And incident and new onset NAFLD was associated with central obesity, general obesity, diabetes, and raised triglycerides at baseline. So this was looking at the people who developed new NAFLD in 2014 and going back and looking at the risk factors in 2007. There was also association with increasing waist and increasing weight. And so more than 5% increasing in either waist circumference or weight was associated with new onset NAFLD. That is, so these patients were putting on weight and they were developing central obesity. That was the risk factor for development of NAFLD. Interestingly, about 12% of our patients were lean. So they would, generally they would look non-obese, but if you carefully look at their waistline, they would have central obesity. And this is a very important thing to recognize because we tend to miss these lean patients. These lean patients tend to do as bad as the obese patients. So this group should not be neglected. We also showed that the incident diabetes rate or the new onset diabetes was much more common, twice as common in those with NAFLD than those without NAFLD. So we took the initial cohort, after 7 years looked at who developed diabetes, and it was the people who had NAFLD. So subjects with ultrasonically diagnosed NAFLD had an increased risk of developing future diabetes. That is also very important, highlighting what is described in the Western literature. Then also we looked at what happened to these NAFLD patients after 7 years. So initially these subjects were given general advice on healthy lifestyle and increasing physical activity, and they were encouraged to attend community clinics. Unfortunately, their attendance was very poor and there was no improvement in physical activity levels at all. And what did we find? That they had very, very modest, very 2% reduction in waist and waist circumference, probably due to them getting older and not them adhering to any lifestyle modification. So we found that none of the patients who had NAFLD, not a single patient, had resolution of NAFLD. That's which is very alarming. So once you have NAFLD, if you don't adhere to strict adherent guidelines, sort of lifestyle and physical activity, NAFLD is not going to go away. So we need a higher percentage of reduction in waist and weight, at least 5%. 10% would be ideal. We also looked at the utility or the diagnostic criteria for ultrasound criteria for NAFLD in our population. So the accepted standard criteria is moderate to severe NAFLD, defined by 2 or 3 criteria, which I described in the ultrasound slide. The intermediate NAFLD was just only one criteria, and that is the increased echogenicity. We just wanted to see who are these people with just one criteria, increased echogenicity. So what we found is that the stricter criteria, the 2 or 3 criteria, is the criteria that defined new onset metabolic traits and cardiovascular events. So the people who had more ultrasound criteria did worse in getting new onset problems, metabolic and cardiovascular. But interestingly, both the moderate to severe NAFLD and the intermediate NAFLD with only one criteria, that the increased echogenicity, had higher prevalence of adverse anthropometrics and metabolic traits at baseline. So having that just increased echogenicity showed that they had diabetes and other problems. So we cannot neglect the increased echogenicity criteria alone. So probably we should be diagnosing fatty liver just on that criteria as well. And that's just a suggestion from this paper. That would remarkably, exponentially increase the number of patients having fatty liver on ultrasound, because then it will become very, very common. So what do we know about the epidemiological studies among special groups? So what I have described so far were findings for a study among urban adults. So what about special groups? This is a collaboration between our group and our pediatric colleagues. We looked at the community prevalence of adolescent NAFLD. These are 14-year-olds. And that the prevalence of NAFLD was very high in this group as well. We did not expect this. It was about 8.4. And adolescent NAFLD was also associated with metabolic derangement, especially obesity, insulin resistance, and early cessation of breastfeeding. And this is work from our obstetric colleagues, again from Ragama, looking at NAFLD among pregnant mothers. Again, an alarming 18.2% of pregnant mothers had fatty liver. These are relatively young reproductive age group. We would not expect them to have fatty liver, but they have. 1/5 of patients had fatty liver. And unfortunately, the women who had fatty liver had a twofold increased risk of developing gestational hypertension and preeclampsia. So their outcomes were poor. It was just not an ultrasound finding. Their pregnancy outcomes were also poor. So coming to studies on the outcomes of NAFLD in Sri Lanka. So this is our 10-year follow-up study. We looked at the 10-year, we looked at the cohort after 10 years. We compared the mortality risk in patients with and without NAFLD in the cohort. And we found that only increasing age, male gender, the presence of metabolic syndrome, but not NAFLD, was the risk factor for all-cause mortality and cardiovascular mortality. So NAFLD was not a risk factor after 10 years for mortality. But if we looked at the NAFLD cohort only, we found that the NAFLD people who also had metabolic risk factors, the NAFLD with diabetes, NAFLD with hypertension, dyslipidemia, they had increased all-cause mortality and cardiovascular mortality. So NAFLD in isolation is not the problem. It is NAFLD plus the metabolic risk factors. So again, the importance of screening our fatty liver patients for coexistent metabolic risk factors. Coming back to the new definition, we also looked at how the new definition performed against the older definition. And we found that there was a very large overlap between the two groups. So about 90% of the fatty liver population fulfilled both definition criteria, but MAFLD was able to catch a slightly better proportion than NAFLD. So what was interesting was that both NAFLD and MAFLD had similar metabolic traits at baseline and similar outcomes, new onset metabolic traits, as well as fatal and non-fatal cardiovascular events after 7 years. So probably, even though the definitions look very dissimilar, we are describing the same disease in this population, which is steatotic liver disease. This is looking at survival of patients without transplantation in our liver unit, and cryptogenic cirrhosis, which is probably NASH cirrhosis, very likely in the absence of any other cause for etiology. And these patients did as bad as the alcohol cirrhosis patients, and death in both groups were predominantly liver related on follow-up and was predicted by increasing age and advanced child class. This is data from our Colombo North Center for Liver Disease Transplant Registry. And we looked at how many patients that presented for liver transplantation had NASH, NAFLD-NASH. And alarmingly, even 10 years ago, 60% of our patients had cryptogenic cirrhosis or NASH cirrhosis that were referred for transplantation. So it is the leading cause for liver transplantation in Sri Lanka. This is from the same transplant registry. This is potential live liver donors. And here also, about 45% of the donors were rejected simply based on the presence of fatty liver. So for a new transplant program, this was a real big problem because half of our patients, donors, liver donors, were rejected based on the presence of fatty liver. This is post-transplant outcomes. Looking at our post-transplant cohort, most of our patients gained weight post-transplant. As a result, all of them, 100% of them, had graft steatosis. So the disease was coming back even after transplant, which is a problem. This is data from our HCC registry. And when we looked at that, 60% of our patients were NASH-related HCC. It's not uncommon to see 1 or 2 new HCC patients for a day in a hepatology clinic with NASH-related cirrhosis. So it's a big problem. So putting all these numbers together, if we extrapolate this to the Sri Lankan population, which is about 22 million, the adult population is about 14 million. 30% of that adult population, we know, 33% will have NAFLD, 4.6 million. And we know that about 25% of the NAFLD patients will have the aggressive disease, NASH, 1.1 million. And about 5% of them will end up in cirrhosis, almost 60,000. That's a massive number when you consider the amount of healthcare resources that is needed to care for these patients. And with advanced liver disease, the number of transplants that we are able to do, and there is a big discrepancy in what we are able to offer to these patients and what we can really do. So the need is much more than what we can do. So as Hagrid is here warning Harry about the impending doom and the gloom of Lord Voldemort getting stronger, so there is a storm coming definitely, and we all be best ready when cirrhosis does, and that is NASH cirrhosis. So in conclusion, ladies and gentlemen, follow-up of the RHS cohort has enabled us to better characterize non-alcoholic fatty liver disease in our Sri Lankan population. NAFLD is on the increase, 33% prevalence and about 6.6 incidence. Lean NAFLD is rarer but is still present and is important metabolically. We should not neglect the lean NAFLD. Subjects with NAFLD have increased risk of developing future diabetes. NAFLD is unlikely to resolve without supervised lifestyle change to achieve target weight loss, more than 5%. Mortality in NAFLD is associated with being metabolically abnormal, so always screen for the metabolic risk factors and correct them. Although increase in the index population was small, NAFLD, MAFLD, both are probably similar. Improved clinical utility slightly. Increased hepatic echogenicity alone and not only the more stringent criteria is probably sufficient to diagnose fatty liver, up for debate. The prevalence of NAFLD is high among Sri Lankan adolescents, and about 18% of our pregnant women have NAFLD, and NAFLD is an independent risk factor for development of preeclampsia. About 60% of our liver transplant referrals are NASH cirrhosis, and about 60% of our liver cancers are NASH cirrhosis related. And therefore, we anticipate a significant increase in liver-related complications and resulting high healthcare utilization related to NAFLD in the near future. It is probably already upon us. I will probably answer questions and comments later on. Thank you.